Hey everyone, Kelsey here today to introduce you to a new CDHF Talks. You're probably used to seeing me with my sidekick Alex, but we are currently working from home right now due to the pandemic, so she cannot be with me here today.
Aww.
So today we'll be talking about a condition called childhood or pediatric eosinophilic esophagitis, or EoE for short. You may have heard of esophagitis before, which is a condition caused by inflammation in the esophagus. EoE is a chronic or long-term immune condition that occurs when eosinophils accumulate in the esophagus, causing inflammation. Difficulty swallowing, vomiting, abdominal pain, chest pain, and heartburn are some of the symptoms that occur with EoE, and they may differ based on the children's age. We are happy to have Dr. Vishal Avinashi with us today to talk about pediatric EoE, the signs and symptoms, diagnosis, and the treatment options. He will also be answering questions specifically about managing EoE in children. So let's get to it.
Eosinophilic esophagitis is a condition that's caused by inflammation in the esophagus. It's a long-term condition, which we call chronic, that occurs when eosinophils accumulate or there's too many of them in the esophagus, causing problems. An eosinophil is a type of white blood cell found in your immune system normally. On its own, it's not a problem, and it can be quite helpful, actually. It's involved with responding to allergies, drugs, even fighting off parasites and other infections. But when we have it in the digestive tract, specifically in the esophagus, that's where we see there's problems and it causes inflammation and symptoms. We shouldn't have eosinophils sitting in the esophagus. Signs and symptoms differ per person, and particularly by age. In the youngest group, which we say are infants and toddlers, it's quite hard to figure out, obviously, because they're not verbal, but one of the signs or symptoms can be related to them not moving towards more textured foods or solid foods. Other kids, it may be actually problems with growth because of their poor intake or their discomfort related to eating. As they get bigger, it can be a still variety of symptoms like those, but also it could be things like vomiting, difficulty swallowing, or complaints related to abdominal pain. In school-age kids, then it's more classically vomiting and abdominal pain, and this is where it can start to have difficulty swallowing. Once they're older kids, particularly by the time they're teenagers, the most common condition is called dysphagia. And that means it's difficult to swallow. It can feel like food gets stuck. It's sometimes even painful to swallow. And it's particularly even textures that bother them, such things like that are dry or thicker, like steaks or chicken breast or breads or rices. They can feel like they get stuck. Less specific things that aren't unique to EoE, which is eosinophilic esophagitis, is chest pain and heartburn. The compensating symptom that all the patients have is they tend to slow their eating down, so they'll be slow eaters. They're often the last at the table. They tend to compensate by chewing their food more extensively, and they often have a glass of water right beside them, where every few sips or even every sip at times they'll be drinking to help wash the foods, almost lubricating it to get it down. The ones who have these symptoms, it usually happens for quite some time, but occasionally there's not much lead time, and it's the ones who present with food stuck in their esophagus, and that is called acute food bolus impaction. So how is EoE diagnosed? Well, you need the combination of both the right pattern of symptoms and the procedure called upper endoscopy with biopsies. The endoscopy is something that seems daunting, but it's a flexible camera that goes through the mouth when the patient is asleep, that passes through the mouth and goes down into the esophagus. This allows us to both look directly to the area, as well as take the important biopsies, which we can look at under a microscope. And that's where we look for whether those extra eosinophils. Once we do that, the pathologist helps us out, and then they actually count the number of eosinophils in a single standard view. And if they can count more than 15 eosinophils in one standard view, match it with the symptoms, that's how we officially label the diagnosis of EoE. Presently, while many researchers have looked for different ways to follow this condition, we're still stuck for now with endoscopy and biopsies. They've explored blood tests, urine tests, swabs of cheeks and other things, and it doesn't seem to be able to provide the same follow-up that we need to give that actual number of eosinophils in the esophagus. We will, of course, ask about symptoms, but that's not perfect in terms of matching. Some people have lots of symptoms and minimal inflammation, and some people have lots of inflammation with minimal symptoms. So it's one of those things that we need more than just the report. Food allergy testing is a great area of interest. And while there is through allergists skin prick testing or even the blood test, those are still best and most accurate to reflect on immediate type reactions. There is some minimally invasive tests called, for example, one is esophageal string test, where this is a pretty simple string that's essentially put in a capsule, it's swallowed, and then the end of the string is taped to the child's cheek. The string can sit there for as little as 1 hour and then later pulled out. And then it's not so much they can get the tissue from there, but they can measure proxies or other types of protein that give us an idea if it's active or not. There's also a sponge test where it's a swallowed capsule, and similar idea where something's in the stomach, it expands, the capsule dissolves, and there's a mild, like a stronger sponge that's pulled out. And in that sponge, you can actually both look at the proteins, but also actually get tissue and still look at it under the microscope. These are still kind of being validated, although some groups have demonstrated it works. The last next promising piece, it's not an alternative to scope, but it's a different version of a scope. There's a transnasal scope, which is a much thinner endoscope, which the idea is you can avoid the anesthetic by placing a thin, smaller type scope through the nose with the patient, like more in an office setting, and it's good enough to get the standard biopsies. Even if they're smaller, they have been validated that it can work to at least demonstrate what's going on in the esophagus. So that's something that you'll hear more about in the upcoming months to years. There's not one single treatment for EoE. There's quite a few different approaches, and it's quite individualized based on patient preference, family preference. There are two general categories. The first is medication, and the other is dietary treatment. I'll first talk about the first line that we often use is called a proton pump inhibitor, or a PPI often referred to. That is used for not just EoE, but as a standard antacid, something that blocks the stomach's acid production. This is something that we use for a variety of other conditions and can help even with healing ulcers and the esophagus. But interestingly, it has been shown even in EoE, separate to the acid blocking, that it does help patients' symptoms improve, and in quite a few people, even improve the eosinophils. The next type of medication that we talk about is called a topical steroid. So it's not going through the system, it's going directly to the esophagus. And this is a type of category called corticosteroid. This is not the same as what some people think about with steroids, like the anabolic steroids, or affect any type of muscle strength or performance enhancing abilities. But these are the ones that control inflammation. They're different versions of how to get it to your esophagus, but both are still called topical. The first is a liquid, and the other one is a puffer. And both work nearly equally effectively, but they work directly on the esophagus and have benefit for the patients. The idea is, we control the activity and the inflammation from the eosinophils from these medications. The idea is that we have it in our esophagus without any food or drink for at least half an hour, and more time is even better. One of the side effects of those is that you can get thrush, which is a type of fungus or candida in the mouth that's overgrown. So we do recommend that the patient rinse their mouth and spit after they do and not eat for 30 minutes at least. It's true that, as I mentioned, the medications are borrowed from other conditions, whether it's from asthma or otherwise, but we are hoping that in the very near future, we'll have meds dedicated and specifically researched for EoE. Now, the other big category that we talked about was diet. Diet is something that there's a wide variety, and this has to be discussed with your treatment team, including your, whether it's a gastroenterologist. It's great if you can work with an allergist and a dietitian, but there's a wide variety. We know that one of the more common food eliminations originally was described as the 6-food elimination. It's not an easy one, but it's removing dairy, soy, egg, wheat, nuts, and seafood from the diet for usually at least 2 months, and then going back and seeing with the scope to see both if symptoms have improved, but also if the histology or the number of eosinophils has improved. And if it's worked for you, then you go ahead and, by process of elimination, add back in the diet certain food groups, and then typically go for a rescope after that. There is inverted versions of that where they've gone for the most common triggered foods, which is called single food diet, and that'd be, for example, removing dairy. Or there's other versions where they say maybe the fine balance between best yield and decreasing the number of scopes and not doing too many is taking away dairy and wheat. So that's called a 2-food elimination diet. No matter which way, you have to have scopes to evaluate these. There is a lot of nuances, and it's not something we tell people to kind of go about themselves. It has to be motivation from the patient, family, and support to make sure that we're balancing whether it's, for example, there's other anaphylaxis and food allergies, which is not uncommon in this population, versus foods that they really are reliant on, what's their baseline weight. These are all important things kind of related to the decision of which foods or which things to eliminate, or if to eliminate at all. There is also, you may read about or hear about, an amino acid-based diet where essentially you can't eat or drink anything, but you have to drink only the specialized protein, like broken down protein formula, and that's called an elemental diet or an elimination diet related to that. It's not meant to be a long-term therapy. It's really meant to be to kind of stabilize or bridge, even if it's described as the most effective therapy where, you know, almost everybody having improvement of their eosinophils, it's not sustainable to only drink a formula, which in the past has not tasted very good. It tends to be quite expensive. And so as a result, we have to be thinking maybe for a few weeks if that's appropriate, but you need a longer term treatment strategy than that. There are 4 common risk factors for EoE. The first is sex. The second is race. Third is having an atopic background, and we'll explain what that means. And fourth can be a family history. With the first one, with being a sex, we know that males are definitely more affected than females. Anywhere from about, it depends on who's describing, but at least 2/3 to even 3/4 of patients affected are males. But with all these risk factors, none are exclusive, meaning it's not as though girls can't get it, or if you don't have a family history, you can't get it. With race, it is something that's previously been described as a problem amongst Caucasians more so, and depends on your environment where you are. We're also seeing it in South Asians, like people from the Indian subcontinent, for example, but seems not as represented in Southeast Asians. Again, not universal, and there are patients that we have from all ethnicities and backgrounds. The third risk factor is atopy. And this is can be one of the tip-offs for whether we should look for this as well. Atopy is a general term we use for tendency to develop allergic type conditions. That could include, for example, eczema, asthma, environmental allergies, or sometimes we call it allergic rhinoconjunctivitis, but that's a kind of fancy way to say kind of hay fever type thing. At least 2/3 of our patients have a background of at least one of those conditions. And sometimes once you have one, you kind of cluster to have more. But again, a 1/3 or even a quarter of our population don't have that. So it's not protective to not have that background. You can still have it in a patient who has none of those things in their past history. And family history, if it's there, for example, if, for example, father has a condition where he's had difficulty swallowing, or even better yet, they've had a history of difficulty swallowing or food getting stuck, that's great. That'll make us think of it even quicker. But for the most part, about 90% of our families don't have any family history. So it's still something that we ask about, but it doesn't need to be there. So remember, with these things, we're still learning a lot about our risk factors. And it's a relatively new condition in the sense that this was really only described in the late 90s in terms of, and our following of these patients has been better and more systematic for 20 years. So as time goes on, we are hoping to better understanding the individual risk factors, but these are the most common ones we have right now. In terms of triggers, we definitely think as food as the dominant trigger, but as you know, for humans, eating is a necessity. So it's not something you can fully avoid, but that's where we talk about individualizing it to see if individual food groups are a trigger for the individual patient. As mentioned, dairy and wheat are common ones. Doesn't mean they should fully avoid all the time, and there's patients where it's not their trigger. So we have to find the right balance. And it is true that after diagnosis, the first few years, it's more trials and errors until we kind of narrowed it to a small group, especially if we're doing dietary elimination. And it does mean several anesthetics related to several scopes in the first few years, and then we can get into maintenance. In addition to the foods, there is epidemiologic, which means kind of larger associations with environmental allergies as well. Especially some describe a seasonal effect. If you're, for example, sensitive to grass, maybe some people are describing worse problems through kind of spring and summer. So that's another thing, but again, that's not for everybody. EoE is not a classic genetic condition where it passes down from one generation to the other, for example, parent to child, but it is something we are seeing in clusters. We have some families where, again, I keep referencing dad because that's the more common scenario, and the kids are affected, but that's not the norm. In our group, we see about 6% of the patients have like a core or a close family member with EoE. And there are some genetic studies, but again, it doesn't seem to be the dominant piece related to explaining why people get EoE. More research is going to come out on that as well. Unfortunately, at this point, I would have a hard time saying, both myself, other gastroenterologists and researchers, that we don't have a perfect and complete understanding. What we can tell you is that you haven't done something wrong. It's not a result of only being urban versus rural versus being born in a certain place. It's not because they had too much Halloween candy. But it does have something to do with the type of immune system that reacts. It's almost over-responsive, and there is some link into some of these allergens or atopic backgrounds that we talked about. But what we do know is this: we're more aware of it now compared to 20 years ago, but we are seeing an absolute increase in the number of cases, particularly at this center, and it seems reflective across Canada as well. So we don't think of this as a congenital condition, which means you're born with it. But, it's sometimes hard to know how early it can start, as we do have patients presenting as infants, even under the age of 1. We often are resistant or not very keen to do scopes very early in months. And there is a fair amount of overlap between fussy feeders, colicky babies, reflux, cow's milk protein sensitivity that can seem a lot and overlap with EoE. And some of those you do outgrow. So it often does take us some time longer to kind of figure out that it is that related diagnosis. But certainly if there is poor growth, as mentioned earlier, that's something that may help us trigger into it. If it was purely a congenital thing, it would all present early, but we have patients presenting more often in older childhood, teenage years, and even some people, of course, as adults who tend to have a longer time before they get their diagnosis figured out. That's an important and interesting question. As mentioned, we've only been tracking this condition for about 20 years, so we actually need more time to figure this out. What I mean by this is we can be biased if we're only following the most severe patients, as there are plenty of people out there with EoE that actually don't know it yet. And there is variability. What we worry about, and the ones that we probably deal with the most, are the ones that actually get narrowing of their esophagus. And we can do backwards looking and say, well, you know, there's numbers such as half patients after 10 years of untreated EoE will have narrowing, but I do believe there's a lot more patients with it that likely don't even know it. So answering the question backwards is, will they have it going forward? For now, we are telling people that this is a condition that they will continue to have. Having said that, it doesn't necessarily have to be a major problem. And, you know, maybe the ones that are found, like was mentioned early in life as infants, they may be the ones that with their overlap of other things that they can outgrow, those are the ones we need to follow and continue to see. So it just highlights the importance of following with your gastroenterologist and talking about both maintenance scopes as well as clinic appointments. So the answer to that is absolutely. It's true that giving a label of a chronic condition means a long-term condition can be daunting for people, but ultimately that's how we know we're doing a good job, is if your child or, you know, the patient themselves is annoyed by having to have follow-up, but, you know, having normal activities, physical activities should be no different. School expectations are no different. Career ambitions are really, you know, there's no reason to tailor or alter those. And really, we know we're doing a good job if their quality of life is good, number one, they have minimal symptoms, and then let us worry about what is the last count of the eosinophils. It's an important thing to have in context, but overall, we expect every child with EoE to be leading a fruitful and healthy, long life. So that's a good question. I think we've talked about how at presentation there's different symptoms that may present, and sometimes there's overlap. But it is true that you know, once they're well-established, school-age, teenagers, I do believe that the symptoms are relatively stable over time. We are interested in studies in how patients transition from childhood to adulthood. And, you know, there's some interesting findings in terms of, you know, one, it goes from a reliance of parents reporting to the patients themselves. And sometimes there's even a difference. So we even ask sometimes separately, what do you think are your symptoms? How often do you have, and how bad is it? And they don't always match what the parents are saying. But it is important to kind of keep tabs. It's partly true that the patients get used to these symptoms. And that can be a good and a bad thing. Sometimes that allows them to minimize them or not acknowledge them as significant. But for the most part, they adapt to it. One of the things we don't see change a lot, even when the inflammation is controlled, is those kind of defensive type practices where I say they're kind of slow to eat. And, you know, they tend to still always, you know, if they felt more comfortable with wash, or even if they've had a choking episode, it's still going to be a long while before they really truly feel comfortable in eating the same food or eating at the same rate as others. But for the most part, you know, it's generally stable, and it's not necessarily a worsening course with time. So it's not kind of the analogy of a time bomb necessarily, but highlighting the point is everybody's individualized. You do need follow-up with your GI doc, and they're the ones who are going to check in with you. And it's really too much for you to say, are your symptoms the same as they were a year ago? If you have someone helping you keep track of that, it's a lot easier. So keep in touch with your pediatric gastroenterologist as a child and make the shift, even if you're feeling pretty well, to your adult gastroenterologist for ongoing long-term continuity.